So now we'd like to open the next session. So this one will be chaired by Dr. Berba. Thank you very much. Good evening.
Okay, so good evening and good morning, everyone. I'm Regina Berba, and I'm the chair for this session. It's Plenary 7, entitled Long Haul COVID-19, Close and Long Encounter with the SARS CoV-2. I feel extremely honored to be here and part of this session and have the distinct privilege to introduce our next esteemed speaker. Dr. Paul Garner is Professor of Infectious Disease at the Liverpool School of Tropical Medicine, which is in the United Kingdom. We know him best as the coordinating editor of the Cochrane Infectious Diseases Group. And because of his team's work, the review portfolio has helped shape policies in the control of malaria, tuberculosis, and other neglected tropical diseases. Dr. Garner also runs the Center for Evidence Synthesis for Global Health, and he is director of the Research, Evidence, and Development Initiative, or the REDIT, and the person responsible for the WHO Collaborating Center for Evidence Synthesis for Infectious and Tropical Diseases. Now, in March 19, 2020, Dr. Paul Garner was diagnosed to have COVID-19. And in early May of 2020, he released his story. His personal account was one of the first published narratives that people at home could have a protracted illness in the BMJ. The Guardian report that followed had 5 million views within 24 hours. And in further 4 blogs over the next few months, he described the relentless course, the exhaustion, the mental fatigue that was very prominent. Dr. Garner has described the strategies he found that helped him recover. So to tell us firsthand about this phenomenon, please help me warmly welcome Dr. Paul Garner.
Thank you so much for that introduction, and I'm very pleased to be here and back with my friends and listening to Marissa. Actually, we've known each other for a long time, working on IVIG many years ago as a Cochrane review. And so it is pretty strange for me to be a person that works in systematic reviews and meta-analysis of thousands of people to be talking about myself in N equals 1. And also to be talking about myself. I don't normally talk about myself, but this did seem a particular point in time where it did seem relevant, where I had something to say. Can I just check the sound is okay for everybody, just so that I'm not proceeding and nobody can hear me?
Yes, Dr. Garner, we can hear you.
Okay, thank you. So, and so I'm very privileged to be here, back among friends. So thank you so much for this. And also, I also don't want to go on for too long about this. I'd much rather then open it up for some questions and discussion. So I should say I'll talk for 15, 20, 25 minutes maybe. At the very most. But you know, I'm in my 60s. I in March last year, or March this year, it feels an age ago, I must say. I was running a lot. I felt pretty. I was doing British military fitness. I'd suffered, you know, in the past. I'd had dengue and I'd had malaria and I'd had a ton of other things. And so COVID was on the scene, and I didn't really see it. I didn't at the time think it was going to be much of a threat to me. And suddenly I got COVID in March 19, and actually I couldn't influence what then happened next, really. And I felt COVID was, the UK government was pursuing a policy of herd immunity. We were preparing to lock down. I was going into work. I was checking my temperature every day. I didn't have a cough. I didn't have a temperature. I had no shortness of breath. But I was on a conference call with Nabarro in WHO, David Nabarro, and he said, this disease has a doubling time at the moment of 3 days. If anybody feels strange or unusual in any kind of way, they must self-isolate. And I started feeling, I felt a little bit strange. So I thought, well, maybe I better be careful. I rushed home and self-isolated. My staff were all furious with me. They thought I should, as a doctor, demand a test, but there were no tests available at the time, and so on. So it was a very difficult time. And the first few days, I didn't actually think I was particularly unwell until a sort of headache kicked in, and you would have all heard the various stories about this. And then suddenly, bang, it came out of nowhere. I almost collapsed. I deteriorated with very a severe I had some shortness of breath, a rapid pulse. I had a blinding headache and absolute fatigue. I couldn't lift my arms or do anything. And so the only thing I could do was go to bed. And I lay in bed and I thought this must be myocarditis or something. I was Googling myocarditis as I sort of passed out. I mean, lying down, passing out is a pretty weird thing to happen. And I actually thought I was dying at the time. And a number of other people have noted this very severe exhaustion and systemic effects being related to this. Maybe my SATs were down, I just don't know. But a few hours later, I woke up and there I was. Then I started this illness that then went on for just, well, months actually. And as you will have come across with your own selves and with your own families and others, it just sort of, the disease is completely random. It goes away a bit and you feel a bit groggy, and then the next morning you wake up, you've got feel as though you've drunk a bottle of Sambuca and run a marathon, and you have ringing in your ears. You just feel completely wrecked, and then the next day you feel a bit better, and it seems to have this cyclical trend, and every day you think, oh, I feel better today, or I feel worse, or it's gone, it's going to go. And at the time, the British government was saying, and everybody was saying, this disease lasts for 14 days, maybe 3 weeks if you're unlucky. And so every day I was Googling these recommendations, and every day I was looking at my clock saying, well, I'm still not well. And at 6 weeks, I was in touch with Fiona Godley in the BMJ. I said, there's something weird going on here. You know, it's just going on forever. So I wrote the first personal view about it. And indeed, in those first 6 weeks, there was every day was something new. Like I'd get an acutely painful cough one day. I'd have tinnitus. I'd have buzzing in my arm, sort of this paresthesia, the tingling in your arms and in your legs. I was breathless one day. I woke up with palpitations in the middle of the night once. I woke up with fasciculation in the middle of the night. One morning I woke up and I had arthritis in my hands. I had weird sensations on my skin one day. I'd be acutely sweaty at night. I'd get up in the morning and I'd feel cold. I'd put 4 or 5 layers of pullovers on because I felt so cold. I mean, it was really bizarre. And the other thing is I'm a pretty resilient character, but God, it gets to your mood as well. So you must be careful with your patients about what's going on for them. You'd wake up in the morning with your head full of tears and pain and just crying, and then by the afternoon you'd be fine. And it's so the virus and the effects of the virus do these things to your mood. They are not just because you're in lockdown or just because you are ill. The virus affects your mood in very dramatic ways, and buzzing in your head and ringing and so on. and so that went on for months, and I just and the response to the first article was very interesting, because there was a flood of emails came in that people said, and because we were all nursed at home, I hadn't seen a medical practitioner at this point. I was entirely alone at home, and so was everybody else in the UK, because everybody was instructed not to go to hospital, and if they dialed 111, they'd just get a bit of advice and stayed at home. And so after this article came out, and the Guardian newspaper article came out, there was a slew of emails with people saying, thank God you said that. I've been going through this madness for months. I thought I had gone crazy. There were people that thought that they had developed a mental illness during this time, because it was so strange. I had weird experiences of friends in Australia who were working in hospitals sending me photos on WhatsApp of a picture of me on the front page of the Guardian saying, I hope you'll get better. It was this sort of public face of being ill was extremely odd. But, you know, the point was that letting people know what was happening and that it was normal was I think, helpful to people. And then I started turning to some of the Facebook pages, and there was a lot of people describing similar things, or similar and different things. But there was a real sense that these people were having all of these symptoms dismissed by their families, and also at that time by doctors. So people would go to their doctor and say, I've got a very rapid heart. A friend who's a psychiatrist went to a casualty department and said, I've got a really rapid heart rate, which we now know is part of long COVID. She said, I've got a really rapid heart rate and I feel really dreadful. And the casualty officer just said, you're anxious. You're just anxious about the disease. This has nothing to do with COVID. And she said, of course I'm anxious, because I've got a very rapid heart rate to do with COVID. So people, you know, people obviously get anxious when they have these bizarre symptoms, but it doesn't mean that the symptoms are due to the anxiety. So I think it's also important that practitioners remember that. And I had some fascinating experiences with my occupational health doctor at work, who said, who interviewed me and then refused to say that I had COVID because I hadn't got a test. He said, this man has had some kind of severe illness, perhaps a virus. And I refused to sign off on it because it was so outrageous. So you were seeing a professor in evidence-based medicine talking to a doctor, saying how ill he was, that was completely consistent with COVID, and them saying, oh, it couldn't be COVID, it has to be something else. I mean, actually reflecting back on it, you know, I didn't let you know, but I had anosmia very early on. And the reason I knew that was there was a couple of people living in the house at the time, doctors, and we were bleaching all the surfaces to keep everywhere clean. And I thought the bleach was inactive. I thought I couldn't smell it. So I thought, oh, I must have had it for too long. And I was bleaching the surface, and I thought, well, it's just, you know, it's just gone off, and so put my hands on the cloth and then took my hands off, and my skin was all sort of peeling off. It was horrible. But so there was that sort of 3 months of this intermittent illness that kept coming and going. And then it moved into a more chronic sort of feeling ill most of the time, with feeling unwell, having also acute episodes, dramatic mood swings. I've talked about this brain fog that came in. So this was when the sort of chronic fatigue set in, and the brain fog really is you can't think straight. I couldn't read long documents. I could read a short email, but a whole document, a whole email, I just said to people, I just can't see the words. I'd forget words. When I was trying to speak, I tried to talk to somebody about a review, and I couldn't remember the word for excluded. I said it's discluded, and I spoke to doctors about this, and they thought I was having a stroke and that I should have an urgent MRI. I put this symptom on the Facebook page, and everybody said, "Oh, we've been having that symptom for ages." You know, I told my husband to get those round white things out of the cupboard that because she couldn't remember the word plates. Somebody told her husband that she was trying to say that she had an appointment, and it came out that she had an accountant, and he thought she was having an affair. I mean, it was extraordinary, this sort of muddling of words that was happening as part of this sort of post-viral whatever it was that was going on with us all. So at that time, I turned to websites to try and get some help. And of course, the NHS and other services are usually pretty terrible around dealing with post-viral syndromes and pretty terrible with dealing with people fatigue. They are, you know, usually dismissed, largely dismissed. The websites were absolutely hopeless. I couldn't get any help anywhere. But the areas that I did find help were in some of the chronic fatigue ME association areas where they talked about being careful with your energy and spoon theory and not overdoing it and so on. And there were videos about, videos were helpful because I couldn't read at the time. So I learned that I had to be careful with my energy, and I learned that physical activity, you have to add that together with emotional activity and also mental activity. So if you overdo all of these things, then you make yourself feel unwell. There seems to be a protective mechanism of doing something. And I learned about what is apparently called post-exertional malaise. And one day I felt much better, and I did 45 minutes of HIIT, and that made me feel very unwell the next day. So I started convincing myself I had a sort of chronic fatigue syndrome. And I started being careful about my heart rate, because there was something in the literature, in the ME literature, if your heart rate goes above 110, you will make yourself unwell again. So it was a really difficult time. So this went on to 6 months. I started writing to people because I was convinced that many people were overdoing it. I was a privileged individual at home, able to work from home. I was fearful of others who had to go out to work to earn their money, making themselves unwell because they were overdoing it. And I think actually there were a lot of people overdoing it in this kind of boom-bust cycle that goes on. And I suppose then what happened is I started saying, well, actually, you can't fight this. A friend in Australia said, you can't fight this, Paul. You have to do a deal with the virus. You have to accommodate rather than fight the whole time. And I have always been a fighter and a pusher. But the strategy with this illness is not around fighting it. You have to do a deal with whatever's going on inside your body in order to give you time to recover. I mean, since things started to settle down, the fatigue settled in fairly substantially, but the night sweats started disappearing around about 6 or 7 months. The brain fog was still there. The difficulty with speech was often still there. And I was lucky because I came across through my evidence-based networks a psychologist who really helped me basically understand my autonomic system had gone out of kilter, and that I needed to use my conscious mind to kind of reset things. And, you know, I found it really helpful. I stopped monitoring my symptoms. I stepped away from the Facebook pages. I thought about many happy things in my life. I pushed out the illness with feeling better, not catastrophizing, and I'm now not 100%, but I have to be careful. But I am so much better. I would say I'm 96% of my 95% of what I was before. So, just reflecting back on those on this more broadly in the last 5 minutes or so, this is happening everywhere. Globally, it's happening everywhere. I've had reports from India, from South Africa. I'm guess it's happening in the Philippines. People say that it happens in young people that appear to be, well, I'm hardly young, but people that appear to be fit. I think this may or may not be true. I think people that are fit will recognize impairment in their fitness and not being able to do what they could do before more readily, and are more likely to talk about it. So I'm not sure about that. I think it's become clear that there are a whole series of different forms of long COVID. I've got one that's particularly associated with fatigue. I think fatigue is common across all the syndromes, but other people have very disturbed heart rate issues, rapid heart rates that kick in spontaneously. Other people have continued crushing sensation and chest symptoms. So there are emerging symptom complexes, I think. There is also increasing research evidence on body scans and CTs and of myocarditis. People are particularly concerned about the myocardium. I am not up to date with all the literature on this, but I am an informed consumer. But my impression is that this is a virus and the post-viral syndrome that has never ever been so intensively investigated. I remain to be so many of the functional significance of what's being found needs to be observed to see whether people are permanently disabled or whether people recover. It's very common for people to think the virus is persisting. There's been some recent reports of the virus being found months later in the gut, and it's caused an existential crisis on the Facebook pages, because the long haulers on the Facebook pages really were beginning to accept that this was a post-viral condition, and now they're sort of thinking the virus is still there. I really don't think it is for the bulk of us. It has long gone, and these are post-viral syndromes that we've seen, or infectious diseases doctors have seen over many years. And the catastrophic thinking that comes out of this between people that are unwell, I think, does them damage. It makes people obsess about their illness even more. So there you are. I mean, I said I'd talk for 20 minutes or so. Let's see over the coming years what happens. I honestly believe for many of this is a post-viral syndrome. I do agree that in the sort of 4 weeks to 12 weeks period, there may be persistent virus and funny things happening with other people. We've seen strokes and pulmonary emboli and so on in this age group. So it is a very odd virus that is causing a variety of symptoms. But Epstein-Barr virus, people are ill for 2 years after it sometimes. Chikungunya, as I'm living in a house at the moment, doing convalescing with a young woman who had chikungunya, and 2 years after her chikungunya, she got quite severe arthritis in her joints. It was clearly related to the initial virus infection. So I think viruses do cause long-term conditions. It's just that we have never had this number of people and this number of sort of young mixed people of ages. So many people are disabled by this, needing support, needing psychological support, needing practical help. And as health professionals, we need to help them by reassuring them, giving them practical ways to improve, avoiding catastrophic thinking, and encouraging them to be kind to themselves, get their families to be kind to themselves, and that hopefully they will all recover. Thank you.
All right. Thank you very much, Dr. Garner. That was very, very, very interesting and very articulately shared with all of us. So, in the Philippines, like every week, patients who finished already like 14 days of isolation are labeled as recovered. And actually, I don't know of any current post-COVID clinics that are open for patients who have had COVID. We sort of like discharge them. And like you said, we assume that they're going to be okay after the 14 days. Do you think this post-COVID clinics might be of help to patients who would be suffering or who suffered things like what you experienced?
I mean, I have a personal view on this, which isn't necessarily an informed policy view, because I have to be a little bit careful because I am a patient and I need to stay in my lines of areas that I can recommend. So I'm hesitant about making broad generalizations about policies around rehabilitation services in countries because I'm not an expert in that. But my own gut feeling is that by and large, many of these symptoms will be either dealt with within the home, within the individual, or will reach public or private doctors. So it'll be the first point of contact that people will go to. So I do think equipping in the UK, equipping general practitioners, and I think probably similar CADA in your country, with an understanding of what this long COVID can look like. So I think the first thing is not for specialist services, but to make sure that your general doctors and others are aware of the wide range of symptoms. And because that in itself is quite important in their interaction with patients. So if you go in to a doctor and say, I'm getting twitching under my skin, I'm getting fasciculation just here. I mean, you see on Facebook pages, people have actual locations where it keeps cropping up. And then the doctor doesn't realize that this is COVID. The doctor will say, oh, don't be so stupid, you're just neurotic, you will be dismissed. I mean, Athena Akrami is a professor of neurosciences at University College London. She's top of the game, and she was a long COVID sufferer, went into work and said, I'm aching all over and I'm feeling really down. And her male colleagues, who were also doctors and professors, said, oh, you just pull yourself together, you're just depressed because of this illness and because you're in brackets because you're a woman. She was dismissed. It's reported in the Atlantic. And so this dismissal of symptoms does not help people. It does not help. And I think it has even more serious implications because it drives people out of the healthcare system and into the Facebook catastrophizing and into populations of people with chronic illness that then will unwittingly perpetuate this illness in others. So simply recognizing and listening to patients, and actually, you know, patients and the patient groups knew far more about COVID, and particularly long COVID, than the doctors did at one stage. So you were seeing the Facebook pages who had quite rightly interpreted that the antibody tests were often negative, and that was way before the doctors, many of the doctors had realized that the test was not terribly useful. So recognizing it is very, very important. Then there needs to be consideration, and I've lobbied for this hard in the UK, very clear indications of when to investigate and what to investigate. Now, if largely many of these things are going to get better, then doing whole body scans and MRIs and so on people will often not be very helpful. And of course, these tests are expensive, and if you've got a public health system, the people that will benefit are the shouty middle classes like me, and the poor people won't get access to them, so that it worsens inequity. But, you know, I mean, for example, when I had brain fog and difficulty speaking, there was a push to get an MRI. I kind of wanted one because I had a family history of cardiovascular, of brain hemorrhage. So I thought it'd be best to sort this out. But it showed nothing, and almost all the MRIs with people with brain fog and these symptoms show nothing at all, and is you know, generally would be regarded as a waste of money. So having very you know, people getting Marissa and yourself and the senior clinicians together in your country to consider what guidance should be given and when people should be referred and when people should be tested and have tests and what tests should be done would be a good thing, rather than it being a bit scattergun as it is at the moment.
Okay. Thank you, Dr. Garner. There are some questions in the Q&A.
Yeah.
So the first one is from Dr. John D. Buensalido. He says, thank you, sir, for sharing your experience. After your COVID-19 infection, do you still go out? And if you do, what is included in your must-wear PPE? Mask, eye protection, face shield? So, have you done some special protected socialization after your experience?
Oh man, I was so even though I was really in a state of collapse for some of the time, I'd get out walking. So I think, you know, even at 4 weeks into the illness, I was walking, and I think it's very important to keep people out and about. I did consult quite widely about whether I was infectious or not, and I clearly wasn't. You know, I mean, the infectious bit is when you're much earlier on in the illness, so I am less cavalier about things. I don't catastrophize about getting another infection. Some people catastrophize about going out and they shut down. This fear you get is terrible. I am in an island of 110,000 people where they've had, I think, 30 cases of COVID in total in Grenada in the Caribbean, because they have such good public health control in the country. Everyone wears masks. I mean, everyone wears masks. You go into a supermarket, there's no argument. There's no argument. There's no debate. Everybody wears masks. Here they don't in the street. People respect social distancing, and this is in an island which doesn't have any disease, right? So people are very respectful of it. So, and I follow the good general principles as stated.
Okay, there's another question. Good evening, doctor. I contracted COVID-19 last July. I had controlled asthma before. However, at day 14 of illness, asthma became severe, needing GINA 5 treatment. However, all asthma workup seems normal. So can this be long COVID or COVID aggravating and asthma presenting as long COVID? He says, I feel you. It's really difficult. Thank you.
Okay, there's so many questions. I'm dependent on you for so thank you for doing that. I mean, I do, you know, as I say, I'm not clinically involved in treating people. We know that the COVID lung damage relates to probably things to do with blood clotting and the stickiness of the blood somehow combined with weird immunological things that are going on rather than a standard viral pneumonia. I can imagine someone with asthma then is going to be put at risk, and this is an additional, any kind of lung involvement is going to be an additional risk, but it may not be that COVID causes increased bronchoconstriction. But certainly the people I know with long COVID that have persisting symptoms seem to have this in the absence of clear pathological findings from CT, MRI, or chest X-rays of the chest. And each time I ask those people, do you think this has got an autonomic, a central control mechanism behind it? And I don't know. I mean, certainly the issue with SATs and people being severely unwell with really, but appearing to be okay with very low SATs is also a feature in actually in long COVID. There are a number of people that actually have are running quite low SATs, even though they're otherwise well, and I think that's an area for research. So I can't advise much further than saying I sympathize with you. If you've got asthma, I think I'd be very careful about it, but do consider long COVID can have long-term effects, both in damaging the lung and with potentially autonomic things that are interfering with your regulation of your breathing.
Okay, there's a friend here who asked a question from Mary Ann Langsang. Hello, Paul. Delighted to listen to you up close regarding your personal experience. Thanks much for your talk. Did crowdsourcing help in determining what coping mechanisms work best? Are you writing up, analyzing patterns of chronic fatigue from the millions of people you have written to?
So I thank you, Mary Ann, and I'm delighted to be here too. So in a sense, the Facebook pages sort of stepped in early on. You suddenly had a group of people that were, and in the UK, were all isolated at home. You know, nobody was going out. Everybody was scared to go out. trying to make sense of this illness. The health professionals were concerned about the people dying and all these people put on ventilators that they couldn't get off ventilators. So the communities were helpful in validating what was going on. I am unconvinced actually about how useful they are in identifying strategies, or if they are useful in identifying strategies, then you have to have a pretty strong filter on it. So let me give you an example. On the long COVID doctor site, recently, so this is just doctors with long COVID. I mean, just doctors. I mean, it's people that have a GMC number in the UK. Somebody posted ivermectin and tetracycline, ! This is the cure for long COVID, right? And then there was loads of comments and yeah, I must try some ivermectin. I tried it and tetracycline looks a good drug. And I wrote, ivermectin in some laboratory studies has shown to have some, in vitro studies, some activity against COVID, but you need to take it orally 1,000 times the dose that is normally recommended to have any potential for in vivo. And tetracycline is an antibiotic, and this is a virus, right? Please use the standards of critical appraisal that you would normally apply in your clinical practice to your patients, to yourselves. This doesn't make sense. God, I got such a view. Doctors are useless at treating themselves, you know, and that's why I've been very circumspect about being careful about my own diagnoses. So, and what tends to happen with this illness, and this is another observation that I've had, is because of its random nature, you don't know when it's going to come back, right? You can be fine one day. I'm fine almost all the days now, but you could, you know, when I was ill, I'd be absolutely on top of the world, almost over on top of the world. I was all high on top of the world. And then the next day I'd be bang, rotten, ill and sweaty and terrible. And you couldn't predict where it was coming from sometimes. But what the Facebook group and other groups do is try and suggest there might be something that's precipitating it. So you get into this mindset, oh my God, what's precipitating it? And I was at home and a friend had come round and I was feeling quite good on a Sunday, and they brought cake and then they left, and most of the cake was left. And I hadn't had cake for ages, and I ate 3/4 of a Marks and Spencer's Victoria sponge. Bang, I ate it down all at once. And then I felt terrible the next day. I thought, oh my God, maybe it's sugar intolerance. You know, I put it on the Facebook page. They said, oh yes, it's very well recognized. People, your sugar load will precipitate your illness. And so I became convinced I was allergic to sugar. This is such nonsense. This is such nonsense, Regina. And you know, and then the next time, it was my birthday and I had some little cookies. Somebody made me some little cookies and I thought, oh, I better not eat those because I'm allergic to sugar. And then I nibbled one, and then the next day I thought, well, maybe I feel a bit unwell. Maybe I am allergic to sugar. So they can set up these cycles that I think can be quite, and that's why some of the identity of these long COVID patient groups is very important for validation. But I think on the treatment side, they can result in anecdotal acceptance of things that really don't make any sense. And then these things through Pavlov conditioning can become self-fulfilling. So yeah, so that I think it's got pluses and minuses. And if anybody was ill, I would say get into the Facebook things early on, later on drop out and try and look after yourself or work with medical practitioners and get yourself better.
Okay, so I have time for two more questions. There's a question from Dr. Janice Kowili. Thank you, Dr. Garner, for sharing your experience. I was struck by your statement that we should be patient with our COVID-19 patients. I agree. I have a question regarding long-haul COVID-19. Do you think it's consistent with the post-COVID multisystem inflammatory syndrome? Is MIS a spectrum of illness?
Yeah, I think it is a multi-system disorder. It's a post-viral syndrome. There's sometimes advantages with labeling things. I think if I posted on Facebook to people that I was encouraging, or the people that I talk to quite a lot of people that are unwell with COVID, just to share experiences, because often that can help. And if I said to them, you have, long COVID, you realize this is a multi-system inflammatory syndrome, then bang, it kind of it helps perpetuate this catastrophic thinking. So I don't agree or disagree with that really, but I did talk to someone recently who said that they were doing really, really well. They'd had one or two setbacks, which happens as you with this illness, as you're resolving it, and then they read that COVID remained in the gut, that the virus had been found in the gut, and they went into a downward spiral. So I do think this avoiding, and I think the doctors make the errors with, I've still got a fever, therefore it must be a virus in my body. No, post-viral syndromes, immunology often give you this. Autonomic disturbances will mess around with your temperature. So try and avoid getting into lots of biological explanations. Is it interleukin? Is it this? I don't know. And nobody knows. But the prospect of it sometimes doesn't help people use their mind to overcome what their misfiring autonomic system.
Okay, this question requires just a short answer. Do you have data on how many % of these COVID positive patients who recovered from the illness developed the long haul COVID syndrome? Is it more common in older age groups?
So there's a group that we're working with, as a call later today, trying to summarize and systematically review that. The problem has been really having prospective cohorts, because people like me I'm not even on the statistics of the UK of being a COVID case. I'm nowhere. I'm not a case. So no, and Phil Spector's app in the UK has been useful, but is subject to many people dropping off, particularly when their symptoms persisted. They just got fed up with filling it in. So I think it's a few percent. But if you look at it in terms of Facebook and in terms of talking to neighbors, I've got, in my street, I've got 3 people at home, all with long-term symptoms of COVID, and that's what I know about. So there are friends of children that are taking time off school with long COVID. So it is extraordinarily common, but I would be hesitant of giving an accurate statistic, because I think we need to review the definitions and now it's been looked at. But it's common.
Okay, so we have no more time. We ran out of time. Certainly, this is an eye-opener. The most important thing that I think Dr. Paul Garner taught us today is that we need to recognize that this is fairly common enough, and we need to be aware of it and be patient to our patients. Okay, so I'd like to present the certificate of appreciation to Dr. Professor and Dr. Paul Garner, for taking time to be with us today and for your excellent lecture. Thank you very much, Dr. Garner.
Thank you. I'm very honoured to be back with you and amongst my friends there in your country. Thank you for asking me.
Thank you. Thank you very much.